The outline of the presentation will cover dental caries and diagnosis of the pulp status under deep carious lesions. Then we will look at the management of deep caries and treatment considerations in vital pulp therapy. After that, we will have a look at the outcome of vital pulp therapy procedures and characteristics of currently available materials used in vital pulp therapy procedures. Is dental caries still a problem worldwide? The answer is yes, actually. More than 1/3 of the world's population have caries in their permanent teeth, and the burden of the problem is shifting from children to adults. Previously, it was more common to find grossly carious teeth, such as these ones in newly erupted sexes in young children. But now with aging population, we get to see more and more of deep carious lesions in the permanent teeth of adults, with, of course, greater prevalence in patients from disadvantaged or low socioeconomic backgrounds. The talk about vital pulp therapy is not actually new. It started in the 18th century when Pfaff tried a gold foil placement on an exposed pulp, and then several chemicals were tried in the 19th and early 20th century. But it's actually the vital pulp therapy shaped its goals and started to actually have some scientific background since the introduction of calcium hydroxide by Herman. However, there has been still resistance to vital pulp therapy procedures, and Rebel in 2020 said his famous sentence that the exposed pulp is a doomed organ. Once you expose the pulp is dead, and you have to extirpate it and initiate root canal therapy, and there is no hope for vital pulp therapy. This actually has been reversed completely during the last 100 years, 1 decade. So let's look at pulp response to dental caries. When caries starts into enamel and just into dentine, it stimulates a low-grade inflammation that stimulates the secretory activity of odontoblast, and therefore it lies tertiary dentine formation. Symptoms might be mild at this stage, but when caries progress further into dentine and approaching the pulp, the stimulus will be more intense, and the adaptive immune response of the pulp will be activated. There will be some death of the primary odontoblast. The pulp has to, there will be a differentiation of what is called odontoblast-like cells or fibroblast-like cells with a secretory activity that will lay out reparative dentine. In this stage of caries extension, the symptoms are actually more severe than in the shallow caries category. A detailed review on what cells are activated in deep carious lesions can be read in the publication by Ricucci et al. In 2014, where he questions that there is anything called odontoblasts-like cells. However, as a clinicians, we don't care actually if it's an odontoblast-like cells or a fibroblast. What really matters is that there will be a reparative dentine. And whether this reparative dentine resembles the primary or secondary dentine, it's not actually very important as far as it seals the pulp from further irritation. So I want to ask you a question. If you have a 17-year-old patient attending with low-grade symptoms, maybe like pain on cold or sweet, with a deep carious lesion in tooth 4-6, the pain is stimulated with cold, the tooth is tender to percussion, but it responds positively to sensibility testing. You start caries excavation, of course, under rubber dam, and then suddenly you see bleeding from the pulp. So how would you treat this tooth? Would you attempt pulp capping or palpatomy, or should you initiate root canal therapy? And if I tell you this patient is 14 years old, not 17 years old, and he's having spontaneous pain, not stimulated pain, would this affect your treatment plan? And is there any evidence for changing treatment plan based on severity of symptoms or patient age? I will get to the answer of these questions as we go on the presentation. What I wanted to point to is that current diagnostic terminology of reversible and irreversible pulpitis, as we were taught in our undergrad, does not actually represent the healing potential of the dental pulp because of our limited diagnostic procedures. If you have a patient coming to your clinic complaining of severe pain like this lady, all what you can do is just take history of pain and use your cold test, whether it's an ethyl chloride or a CO2 test, and then you will make a judgment based on predilection of the possible status, inflammatory status of the pulp. If you compare it to when you have pain in your knee and you go and see your orthopedics, he will start with physical examination, he will take x-rays, he will have MRI, he will have endoscopy, lots of diagnostic procedure before he can tell you that you need to replace the joint of your knee. While in endodontics, we just roughly rely on results of cold tests, which is totally unfair on prediction of the healing potential of a very vascular pulp tissue. So is there a good correlation between the clinical symptoms and the histology of an exposed pulp? If you have this radiograph, periapical radiograph of an upper right 6, you see here a deep carious lesion exposing the pulp, or this wisdom tooth with a deep caries reaching the pulp, and the patient in both cases presenting with severe spontaneous pain, which is a clinical diagnosis of irreversible pulpitis. Is there a good correlation between these symptoms and the histological status of the pulp? Is the pulp really completely damaged in the crown and the roots? The first was to look at the correlation between clinical symptoms and the actual status of the pulp was Damar et al. In 1984, where he found that there is partial necrosis. I want to highlight the word partial necrosis in around 90% of painful cases, and there is partial pulpitis in 88% of the cases, and pain was present in 40% of the cases with savable pulps. 40% of painful cases were actually having normal pulp architecture. What does this mean? We might be able to save the pulp. A very well-designed study by Ricucci et al. In 2014, he exactly looked at the histology of irreversible pulpitis and reversible pulpitis. He found good correlation between symptoms of reversible pulpitis and the histology of the pulp. While in patients with severe pain and symptoms of reversible pulpitis, he found that the histological diagnosis is matching in only 84% of the cases. So 16% of the cases, vital cases, receive root canal therapy unnecessarily. I'm showing you some of the cases that he actually kindly gave me, looking at histology of deep caries. Look at this wisdom tooth with deep caries. This tooth was extracted, histologically prepared. This is a closer look. If you look at the pulp architecture, there is damage here because of carious pulp exposure. This is a non-stained section, which can be more clear. This area of pulp damage and bacterial infection. While if you look at the contralateral pulp horn, you see that it's completely normal. Odontoblasts are beautifully lining the pulp space. So shall we compromise this pulp by complete root canal therapy, or would it be able just to remove this infected, inflamed part, place a biological material that will help bridging the defect and maintaining the vitality of the tooth? This is another example of the upper 8 with deep caries. If you look at the histology here, the entire pulp chamber is inflamed, the blue stains indicating bacterial infiltration. But if you have a closer look at the canal, which is this here, you see beautiful odontoblast lining the pulp space, normal loose fibrous connective tissue of the pulp. So if we remove the coronal pulp tissue, the pulp in the canal is completely healthy and we maintain the vitality of the tooth. But why should we attempt vital pulp therapy? Because it has several advantages. The most important one, according to Rondeau and Glantz, is maintenance of the defensive and proprioceptive function of the healthy tissue. If you have a healthy tooth, no root canal, and you bite on a hard object, it will give you a sensation that you are overloading your tooth, so you will open your mouth. But if the tooth is root-filled and you bite hardly on a subject, there is lack of proprioception, which will lead to fracture of the tooth. Furthermore, Merdad et al. Found that endodontically treated teeth showed higher caries susceptibility because caries will start in a root-filled tooth and you will never feel pain until it's too advanced and will result in tooth loss. Also, longevity of endodontically treated teeth, actually, it's not equivalent to that of vital counterparts. And unfortunately, cross-sectional studies looking at the quality, the technical quality of root canal fillings showed that 40% of root-filled teeth are technically inadequate with persistent apical periodontitis. This is a global problem in Jordan, in London, in Sweden, in France, in Australia, in Germany. All cross-sectional studies, unfortunately, show low technical quality of root canal fillings. Several myths exist in carious pulp exposure management. It has been always thought that pulp exposure is a negative prognostic factor when you are excavating caries, and therefore indirect pulp capping is preferable to direct pulp capping, which is not true actually, and it's against the current recommendation by the American Association of Endodontics. And it was also thought for long that only mechanical or pinpoint exposures can be capped. When I was undergrad, and mostly, I guess most of you, we were taught that if the size of pulp exposure is important, if it's mechanical or carious, if it's mechanical cap it, if it's carious, do root canal therapy. This is actually a myth. And we should always disinfect any pulp exposure with sodium hypochlorite. Sodium hypochlorite is not irritant to the exposed pulp as it's used to be thought. And it was also thought that calcium hydroxide is the gold standard material, which is actually not currently. So there are several studies on indirect pulp capping, which means that you leave a layer of soft, affected, hopefully not infected dentine over the pulp and then place a liner and restore. Actually, it's a very challenging procedure because it's very hard to determine if this is a firm or hard dentine, how much you should move. And there are variations in the reported success rates of several studies that looked at, varying from 60% to 83% because of different protocols. Rikuchi et al. Have shown that in his recent publication in 2020 that leathery or firm carious dentine is actually infected. So there is bacteria in that dentine that we leave, and on long term, it may result in pulp necrosis. So he says that it's against biological principles to do indirect pulp capping, and the American Association of Endodontics has followed his recommendation actually, and IPT is not a recommended procedure in the States, while it's still acceptable in UK. The only case where I will attempt IPT is actually in young, immature teeth with symptoms of reversible pulpitis. And this procedure will be interim management until we get complete root formation and we can do further advanced procedures. The reference for what I'm saying in my presentation, and all endodontists are following now, are two position statements. The European Society of Endodontology position statement on management of deep caries lesion in 2019 by Duncan et al. And the very recent one, late 2021, the AAE position statement, where they officially accepted full palpatomy and partial palpatomy in the management of irreversible pulpitis. It's a real paradigm shift in endodontic practice. Let's have a look at calcium hydroxide. We all know the advantages of high pH, antibacterial, and the induction of hard tissue barrier formation. However, in vital pulp therapy, I tell you from the experience of all practitioners and from my own experience, it's very hard to place calcium hydroxide on an exposed pulp because of the hydrophobic nature of the material. It's also soluble with low mechanical strength. So if you try to place a permanent restoration on top, you will end up disintegrating that barrier. And histologically, there are tunnel defects in the hard tissue barrier induced by calcium hydroxide, which will form pathways for further bacterial invasion in case of coronal leakage. Several studies have also shown that there is deterioration of success rates of direct pulp capping using calcium hydroxide. So if you have like a success rate 50% at 5 years, it declines to 20% at 10 years. So the longevity is actually low. This table, I will just pass it quickly because of time limitation, looks at studies on direct pulp capping, starting by the landmark study of Barthel to Caliscan in 2016. I want to look specifically at randomized clinical trials comparing MTA, mineral trioxide aggregate, versus calcium hydroxide. These are highlighted in yellow. If you look at the success rate, 85% for MTA compared to 52% using calcium hydroxide. And again, 85% versus 77%. And these differences were statistically significant. So actually, calcium hydroxide is not used anymore in vital pulp therapy unless you are working in a very remote area where you don't have access to current calcium silicate materials. I want you also to see that there are differences between the studies. Some of them are looking at irreversible pulpitis, others are looking at reversible. In the recommendation, you will see that we don't do pulp capping in irreversible pulpitis cases because bacteria is already in the pulp and you need to remove part of this infected and inflamed pulp. This is just a further look at very well-designed randomized clinical trials looking at a comparison of calcium hydroxide versus MTA, Helton et al. In 2013. He found superior performance of MTA over 2 years. Failure rate was above 30% for calcium hydroxide compared to 19% for MTA. This is also another meta-analysis of randomized clinical trials showing that MTA has a higher success rate compared to calcium hydroxide and more predictable hard tissue barrier formation histologically, because on radiograph you can't always detect hard tissue barrier formation. This is also a study over 3 years by Kudzinia et al. 85% success for MTA compared to 52% for calcium hydroxide. That's why we don't attempt vital pulp therapy using calcium hydroxide anymore. And this study particularly was in adults. So capping carious exposure in adults, it's an indicated treatment modality currently using MTA. This is also a consort randomized clinical trial showing similar, almost 90% for MTA success compared to almost 70% for calcium hydroxide. But I'm telling you, if you work in a practice where you don't have access to a calcium silicate material, you can use calcium hydroxide. If you want a detailed review on the topic and related literature of pulp capping, partial palpatomy, and full palpatomy, you can refer to my review for the pulp biology symposium that was held in the States in 2019. And the proceedings were published in this articles in 2020 in Journal of Endodontics, Conservative Management of Mature Teeth with Carious Pulp Exposure, because I don't think that any two dentists can have controversy regarding management of immature teeth. We all tend to do vital pulp therapy when the tooth is immature, but the conflicts of opinion exist when we have a mature tooth. So calcium silicate cement pulp capping material can be used in a single visit procedure. It can be done in asymptomatic teeth or teeth with reversible pulpitis, rubber dam isolation, then carious excavation. Rubber dam placement is a must. You can't attempt any deep carious excavation without rubber dam. Then you cover the exposure and surrounding dentine with calcium silicate material, place a resin modified glass ionomer or a resin composite restoration in the same visit. It's very important that you attain a good coronal seal in the same visit. This is just quoted from Ricucci et al. In 2019. After carious excavation, we should always assess the exposed pulp, and it's preferable if you have a magnification loops or microscope, because you have to detect the avascular or deconstruction areas like in this, or if you have dentine chips embedded in the exposure site, then tissue removal is required. You can't simply cap this clinical appearance. Deconstruction, debris, you have to remove part of the pulp, either in partial pulpotomy and assess again, or full pulpotomy, but you can't cap such exposure. An exposure that can be capped should be completely filled with red blood, no dentinal chips, no yellowish areas or grayish areas around the exposure indicating necrosis. So this is just an example of a clinical example of a case where there is a deep gross carious excavation. You find that these areas are hard now. This area of the pulp exposure, you can see avascular areas here, so it's not completely filled with blood. Therefore, 2 or 3 millimeters of the coronal pulp tissue were removed in partial pulpotomy, or you can call it Schwick pulpotomy, whatever is you are using. It's the same, partial pulpotomy or Schwick pulpotomy, removal of 2 to 3 millimeters of the coronal pulp, assessment again under magnification, ensure that it's filled with the blood, has normal architecture, then you place your calcium silicate material on top. I want to show you this case of partial pulpotomy using ProRoot MTA, the very original calcium silicate material introduced by Dentsply, late 1990s. This tooth had deep caries exposing the mesial pulp horn. Partial pulpotomy was done. This is 1 year follow-up. This is 2 year follow-up. And there is normal architecture periapically. The tooth is responsive to cold test. I want to highlight that it's not enough that the tooth is asymptomatic. This table is quoted from my paper in 2020. You can always look at it. I highlighted here. This study was by me and my postgraduate students. We looked at mineral trioxide aggregate versus calcium hydroxide, diagnosis of irreversible pulpitis in mature teeth. Over 2 years, we had success rate of 85% for partial pulpotomy in irreversible pulpitis using MTA, compared to 40% with calcium hydroxide, and the difference was statistically significant. There is also a more recent study in 2019 by Thai group. They looked at MTA versus biodentine, which is a non-staining material, calcium silicate material. They found they are both highly successful, above 85%, with no significant difference between the two calcium silicate materials. You can see more of these tables in my paper. This is an example of full pulpotomy, pulp exposure, tooth is bleeding, the entire coronal portion of the pulp is removed. We achieve homeostasis by this cotton pellet soaked with full strength sodium hypochlorite or 2.5%. It's usable. You can use either concentration. This is how it should look after removal of the cotton pellet. You should be able to achieve homeostasis before you can place your calcium silicate material. In this case, we used biodentine. It comes in a capsule, and you just triturate on an amalgamator. You place it in 2 to 3 millimeter thickness over the exposed pulp, place a liner, and then restore with composite, and always take a post-operative radiograph for future follow-up. This is also a full table of several studies starting in the 1993 by a Turkish group leader, Kaliskan. He looked at mature teeth with irreversible pulpitis, with hyperplastic pulpitis, and he used calcium hydroxide at that time, but it was a very thorough procedure, and he got success rate over 90%. No one paid attention to these early studies until MTA has appeared in the market, and we had several studies using calcium silicate materials. They are all showing high success rate above 85 or above 90%. These two studies compared actually pulpotomy to root canal therapy, and they found no significant difference. So pulpotomy is not inferior to root canal therapy in vital cases. What are the evaluation criteria for success? I just passed through them. The clinical criteria, which is absence of symptoms and response to cold sensibility testing. Radiographically, there should be no root resorption and no development of periapical lesions. Proposed prognostic factors for the procedure. Previously, it was thought the pulpal diagnosis, if it's reversible or reversible, will make a difference. Age and root maturity. Periapical diagnosis. But we will see later that these are actually not prognostic factors. You can perform vital pulp therapy in any category of these. Intraoperatively, remaining tooth structure is very important because if the tooth will require post and core restoration, there is no point of performing vital pulp therapy. Exposure size is not important at all. Bleeding and hemostasis is important because you won't be able to place your capping material, the calcium silicate material, until you achieve hemostasis. What is the ideal time to achieve hemostasis? There are studies that looked at vital pulp, performed vital pulp therapy with hemostasis up to 25 minutes. Can you imagine trying achieve hemostasis up to 25 minutes before your calcium silicate material? I have to be honest with you, I never tried that. I only try up to 10 minutes. 5 application of 10 minutes of 2 minutes interval, which is a total of 10 minutes. And we had success rate with all these time intervals up to 10 minutes in our studies. Coronal seal is crucial for long-term success. Sodium hypochlorite is very advantageous because it removes the biofilm. It results in chemical amputation of the blood clot, removed dentinal chips, and it only have a caustic effect on the superficial layer of the pulp, which will induce repair. So it doesn't have any drawbacks if used in vital pulp therapy. And you can use variable concentration from 1 to 6%, apply it for 2 minutes and repeat it up to 5 times, which is a total of 10 minutes. This is another example of clinical procedure. When you perform pulpotomy, you should get this bleeding. If you don't get enough bleeding, I would worry that the pulp is partially necrotic. After hemostasis, you get this. The pulp is just pooling at the canal orifices. Here, calcium silicate material was placed above the orifices only, but I usually encourage that to cover the pulp chamber floor. It will give a better seal. What if you don't get hemostasis? Like this carious pulp exposure, pulpotomy was performed, and up to 30 minutes, blood continued to come like this. The cotton pellet is completely soaked with the blood. Blood is soaking the periodam as well. We can't do vital pulp therapy here. We can't achieve hemostasis, so you have to go to root canal therapy. As endodontists, we are not, I really encourage vital pulp therapy, but there are contraindications to vital pulp therapy when you don't achieve hemostasis. So you go to conventional root canal treatment, which is highly successful in vital cases as well, above 95%. So as I've pointed before, there is no specific study that looked at hemostasis in relation to outcome of vital pulp therapy, except one study on direct pulp capping by Matsu et al. It's a highly quoted study, but actually, if you look at the design, you find that it's not, bleeding has a low specificity as a predictor, because even with the cases that had oozing over 30 seconds, 50% of them would heal. And what's 30 seconds in terms of oozing from a pulp exposure for direct pulp capping compared to the bleeding we get in pulpotomy? So you can't apply his study to pulpotomy or partial pulpotomy. So preoperative clinical diagnosis, reversible pulpitis, irreversible pulpitis. Even when you have periapical radiolucency and you have a vital pulp, you can still perform pulpotomy. Presence of a periapical lesion, it's not a contraindication to vital pulp therapy. I will show you this patient age also is not a contraindication. This 9-year-old patient, open apex, deep caries. This is 25, young patient, and this is in adulthood. All these cases were treated by vital pulp therapy by Matsu et al., Taha et al., and Kaliskan et al. They included a wide range of age from 9 years old to around 70 years old. There is a systematic review by Kashley et al. In 2019 on management of mature carious pulp exposure. Over 3 years, the success rate was above 88%. 4 studies looked at adults. One of them was my study in 2017, and our success rate was above 90%. I'll give you this as an example. This is new MTA Plus. It comes in a powder and a liquidy gel. You can mix in a consistency similar to IRM, the intermediate restorative material. Advantage of this material is that it's non-staining. I forgot to declare I don't have any interest of a special material or special company. I've used all calcium silicate materials with my students and in my research, and all of them are perfect and can use whatever available in your hands and you feel comfortable in its manipulation. So this case, in 20-year-old female, bleeding control in 10 minutes. I wanted to show you this case because this was the extreme. 10 minutes to achieve hemostasis. We did palpatome, and this is 1 year and 2 years follow-up, tooth completely asymptomatic, and the periapex is completely normal. This is another example of 8 minutes hemostasis in 8 minutes using new MTA as well. This tooth was tender to percussion. That's why the diagnosis was symptomatic apical periodontitis. I get this question: do you do vital pulp therapy in teeth tender to percussion? Yes, we do that, because tenderness to percussion, it's not indicative of advanced destruction of the pulp. This is an example of a case with periapical lesion, because usually several times or several occasions we get bone resorption before total necrosis of the pulp. It's the inflammatory products and cytokines that induce bone resorption before total necrosis of the pulp. At 2 years, PDL is completely normal around the apex of the tooth. This was my first publication on vital pulp therapy in late 2016, published officially in 2017. We used the fast set MTA Angelus, sitting time of 15 minutes, because that's what we had at that time. It's compared to the ProRoot MTA. ProRoot require 4 hours for initial sitting. In this study, we included both reversible, but mostly were irreversible pulpitis diagnosis. Look at the age, varied from 10 to 59 years old. Apical periodontitis was present in 14 cases. We had success rate above 90% over 3 years. And it paid my attention to the high success rate of irreversible pulpitis. So I decided to look in my later studies on adult teeth, mature roots with diagnosis of irreversible pulpitis. I'm showing you biodentine because it's the one that was used in my further studies. MTA is a perfect material, but it caused discoloration. In this material, the radiopacifier was changed to zirconium oxide, which is non-staining. It comes in a capsule, and you place the water drops in the capsule, you triturate it, and then it's ready for placement. You don't need to mix. We had 2 publications on full palpatome with biodentine in symptomatic young permanent teeth, immature teeth, and 1 publication in adult teeth with irreversible pulpitis. Both cases with irreversible pulpitis, we used biodentine, and the success rate was 95 to 98%, and we are currently working on the 5 years follow-up of these cases, and inshallah will be published during next year. In this study, we looked at variables like tooth type, percussion sensitivity, caries, if it's a primary or recurrent, exposing the pulp or just close to the pulp, number of missing wall, and we looked at bleeding time to see if any of these is a prognostic factor that will affect the outcome, and we found no significant difference of any of these criteria. Palpatome was highly successful. These are examples of the 3 years follow-up that we are doing. We did already last year, but we are doing the 5 years follow-up now. You can see this tooth previously restored, recurrent caries. We did palpatome, 1 year follow-up, tooth is asymptomatic. 3 years follow-up, everything is perfect, and there is no report of staining. Palpatome and vital pulp therapy is very beneficial in wisdom teeth. If you don't want to extract, or if the patient doesn't want to extract, you can always attempt. This lower wisdom had deep caries exposing the pulp with periapical radiolucency. This is 1 year follow-up, 3 years follow-up. Amalgam restoration was placed because of difficult isolation in that area. but mostly we place resin composite, and the patient was 57 years old. He's an employee at our dental hospital, and I will show you the 5 years follow-up of this case. So is there a difference between partial and full palpatomy? Actually, both were found to be successful by reviews El-Mesmari et al. And Al-Qadiri. In cases of reversible pulpitis, the success rate was above 90%, but I will always attempt partial pulpotomy first to conserve primary odontoblast and be able to do sensibility test. So if partial pulpotomy works, I will return the remaining healthy coronal portion of the pulp. I will not attempt full pulpotomy since it's highly successful as well. This is my publication on partial pulpotomy published in Journal of Endodontics in adult teeth and symptoms of irreversible pulpitis. So adults above 20 years old, irreversible pulpitis, intervention was partial pulpotomy, calcium hydroxide versus MTA, and we had an 85% success rate. You may say that 85 is below, slightly lower than that for full pulpotomy in cases of irreversible pulpitis. This is totally true because conventional wisdom, if you remove the entire coronal portion, you are more likely to remove that infected, inflamed portion of the pulp compared to partial pulpotomy. There is only one study that compared direct pulp capping, partial pulpotomy, full pulpotomy, and IPT in the same clinical setting and in irreversible pulpitis. However, they reported success rate of all 4 procedures above 90%. Actually, I and many other workers on vital pulp therapy have very special concerns regarding the results of this study. How would teeth with different histopathology give you similar success rates? If you have infection progress in the pulp chamber, how would pulp capping would be similar to pulpotomy? So we need further studies that compare the outcome of partial versus full pulpotomy in a randomized clinical matter. This is the flowchart that I would like to show you, quoted from Ricucci, 2019, on management of deep caries. He divided if you have symptoms of reversible or irreversible pulpitis. Let's look at reversible first. If there is no pulp exposure, then it's just an ordinary filling, a restoration. If you have pulp exposure, you see sound dentine around the exposure, continuous blood-filled pulp, bleeding control within 10 minutes. I may point that I asked him personally about the recommendation of 2 minutes, and he said that's what he do. But he doesn't mind if you try up to 5 or 6 times. There should be no dentinal chips, then you do pulp capping. If there are areas of necrosis, you could not achieve bleeding in this, you have to go to pulpotomy. It's either partial or full pulpotomy. While in cases of irreversible pulpitis, you have pulp exposure, you can never do pulp capping. Pulp capping is not indicated in irreversible pulpitis. You have to do partial or full pulpotomy. If you have continuous pulp tissue filled with blood, bleeding controlled up to 10 minutes, I would say, then you do pulpotomy. If no, you will go to pulpotomy and conventional root canal treatment. I've already talked about the presence of periapical pathosis. It's not a contraindication to vital pulp therapy. And total inflammation or necrosis of the pulp is not a prerequisite to the appearance of apical periodontitis. It's just a function of inflammatory mediators and cytokines. These are just examples of studies that included teeth with periapical pathosis. Look, starting in the 1993 and up to 2018 with different procedure, partial pulpotomy, full pulpotomy. And according to the review by Aguilar and Linswanos in 2011, teeth with periapical radiolucency treated with vital pulp therapy had high success rates above 90%. This is an example of a young case with fully formed root, but with periapical lesion. This is the 3 years follow-up. Complete resolution after MTA full pulpotomy. This is another example. I get several questions that among them, is root canal calcification a complication or a worry or a threat after vital pulp therapy? I would say no. There is no one specific article that reported the percentage of root canal obliteration. It's not like after traumatic dental injuries or regenerative or revascularization procedures. You might get hard tissue barrier formation, which is more common in young patients. But in adults, if you look at this example, palpatome at 3 years, I could see only here like a dentine bridge in the middle. But if you place a crown in this tooth, you will never need to access the root canal again. So calcification, it's not a worry after vital bulb therapy. These are just arrows pointing to the dentine bridge. I like to share this case with you. With a young patient, he had carious exposure in the upper left 5 and 6. Palpatome was performed in 2, and this is 4 years follow-up. This is the 6. Both teeth are asymptomatic. The 5 has continued root development, but you can see intracanal calcification. This is the only case really of more than 500 cases that we treated at our dental school that we had intracanal calcification like this, mostly because it was young tooth and it's similar response to what we see in non-vital teeth after regenerative procedures. But the patient was completely happy with the outcome. He finished his orthodontics, but unfortunately he's losing this tooth because of deep caries and poor oral hygiene again. We had one case with internal resorption after full palpatomy in a tooth with periapical lesion. So is internal resorption a common complication after vital pulp therapy? No, it's not actually common. I've seen one study that reported a case, and in our studies, we reported a case. So at 1 year follow-up, we had this young patient having this ballooning of the root canals, small ballooning. It was diagnosed as internal resorption, but the tooth was completely asymptomatic, and the parent opted to leave the tooth for further follow-up. And this is, I'm sharing with you the 4 years follow-up of this case. There is resolution of internal resorption, and the tooth is completely asymptomatic. Periapex is beautiful with continuous PDL. So this case showed that even internal resorption, if you keep under a close eye, follow-up, it might heal. It might not be, if it's asymptomatic, of course. If there are symptoms, you should initiate root canal therapy. These are examples of the available materials that we have used in our dental school. This is a total fill bioceramic putty from FKG Dentaire, and this is new putty from New Smile or from Avalon Biomed, USA and Canada. This is Biodentine from Septodont, France. This is the very original ProRoot MTA from Dentsply. New MTA Plus is the earlier version of this new MTA putty. Currently, we are doing our research using this new putty. It has a beautiful consistency. This was beautiful, but this is actually becoming really nicer to use, and you don't need to mix in both forms. You just display it from this syringe and you roll it in 2 to 3 millimeters, place it. All these 1, 2, 3, 4 are non-staining materials. MTA, Angelus, ProRoot MTA, because of the radiopacifier included, they actually use staining of teeth, but they are still biologically beautiful materials. All calcium silicate materials you have seen are hydrophilic, so you can place easily on the pulp, placed in bulk, so they provide coronal seal by themselves. Comparable biological properties to ProRoot, which is dentinogenesis and even cementogenesis. They induce the release of growth factors. And they have actually clinically comparable success rates for biodentine, MTA, and bioceramic. Currently, we have a study under consideration for publication, inshallah, in the international endodontic journals. We looked at in a randomized clinical trial comparing several calcium silicate materials. They were all, the 3 types were equally successful. This is an example of a pulpotomy performed in an adult patient, and we used the FKG bioceramic putty. One of his advantages is the increased ridge density, so you can recognize the material. One point I like to remind you, if you attempt vital pulp therapy, you should explain to your patients best. That's what you are doing. These are other examples. You can see hard tissue barrier formation. This is examples of biodentine, similar success rate. This is pro-root MTA. Again, radio density is perfect. This is pro-root MTA, 2 teeth that I have shown earlier. But this is what the aesthetic concern that we have with MTA limited number. Like we had 50 cases of MTA, 3 of them had this discoloration. It was not of a concern to the patient because it was a posterior tooth. But if it was your anterior tooth, you will not accept this actually. So unless the tooth is going to be crowned, do not use MTA if you have aesthetic concern. Use other brands of the calcium silicates. What is the required length of follow-up for vital pulp therapy? It has been accepted that 2 years is enough for calcium hydroxide and MTA using direct pulp capping and full palpatomy according to Simon, Matsu, and Kaliskan. However, long-term studies of 5 to 10 years are required just to prove the longevity of these materials, because we don't want to get what Barthel et al. Got with his calcium hydroxide studies, pulp capping, when he had 30% at 5 years, dropped down to 13%. But we already talked about disadvantages and disintegration, and mainly these failures most probably were due to coronal leakage actually, because Kaliskan studies of palpatomy using calcium hydroxide were highly successful in the 90% just because of excellent coronal seal. I want to show some long-term. This is 45-year-old male, irreversible pulpitis in tooth 47, full palpatomy. This is 2 years follow-up, and this is the 4 years follow-up. Patient is still happy, tooth is functional and asymptomatic, no radiographic or clinical evidence of failure. This is a tooth with irreversible pulpitis. It was among our study. 48-year-old male, partial palpatomy in the lower left 7, and this is the 5 years follow-up. Tooth is still responsive to cold test, asymptomatic, good integrity of the coronal resin composite restoration. And this is 6 years follow-up. For him, I could see that there is recurrent caries underneath. He was referred for replacement of the composite restoration without disrupting the palpatomy material. Of course, I referred him to someone I trust that he will not disturb our vital pulp therapy procedure. This is also further example of 5 years follow-up. He's a staff at my university, so I have access to him for review every year. Full palpatomy using MTA Angelus, 3 years follow-up, 4 years follow-up, 5 years follow-up, tooth completely asymptomatic, full coverage crown. And the doctor, he has an implant and RCT in his mouth, RCT and 2 implants. So patient satisfaction is actually high, and crown placement is a very major factor in longevity of teeth with vital pulp therapy. A very recent publication of me and my postgrad in Journal of Endodontics, January issue of this year, we started looking at longer term follow-ups of the cases. This case, actually, we did not publish at 1 year because I was planning the long-term follow-up. This is so 4 years follow-up of 100 teeth in mature teeth of 14 to 60 years old. And here we used the new MTA plus mixing type. As I've mentioned, 4 years follow-up, and we did here the statistics of survival analysis. The result was that a tooth with pulpotomy will have an average survival of 3.1 years mean survival time, and the success rate was 91%. We looked at several prognostic factors. We found that the severity of preoperative pain was the only negative prognostic factor. Like we had 2 pain categories, moderate and severe. If the patient was in the severe pain category, the odd ratio of having failure were actually higher than the moderate pain category. We looked at age. If there is a difference, if the patient is younger than the median age of 25 years or above 25 years, but in the logistic regression analysis, it was not a significant factor. So age is not a significant factor. Severity of the preoperative symptoms is the only significant factor. This is an example of one of the cases published in that article. Tooth with irreversible pulpitis. The age is 33. We attempted palpatome. We could achieve hemostasis in 8 minutes. Restored with composite restoration, 1 year follow-up, 2 year follow-up, 4 years follow-up. The tooth is crowned. We can still trace the pulp canal space. Margins are perfect. We are not worried about coronal leakage. I expect high survival and a very excellent longevity for this crowned tooth. In pulpotomy and vital pulp therapy, we get early versus late failures. Usually, early failures are related to endodontic causes, while late failures are actually restorative failures. This is an example of an early endodontic failure. This patient received full pulpotomy. She attended the 3 months follow-up with periapical lesion and history of pain. So if your pulpotomy procedure going to fail, it will fail within the first 3 months. You will not failures because of pulpal causes after a 1 year or 2 years, unless there is a break in the integrity of the coronal restoration. This case was the 6 years follow-up of the employee at our clinics. He came with recurrent caries underneath this restoration, deep cavity, and it's a lower wisdom. There is no way to achieve a good coronal seal with a new restoration. So we decided to refer this tooth, the wisdom tooth, for extraction after surviving 6 years with full pulpotomy using biodentine. So this is just what I wanted to say. Late failures are usually because of recurrent caries or restorative causes. It's nothing due to inadequate diagnosis of the pulp status or inability to heal. So this is the storage graph of the wisdom tooth that I've just talked about, preoperative, 1 year, 3 year, and this is the 6 years. Unfortunately, because of difficulty in cleaning and the patient is not a regular flosser. So here we come to conclusion that there is heaps of evidence indicates that vital pulp calcium silicate materials are highly successful in permanent teeth with carious pulp exposure, at least over 3 to 5 years until now, but hopefully we will get more long-term studies. Teeth with a diagnosis of irreversible pulpitis and even apical periodontitis have the potential to heal with conservative approaches. The secret lies in adequate case selection, strict asepsis. Rubber dam is a must before starting excavation. Good coronal seal is essential for long-term success. I would like to thank you all for your presence and for your attention. And if you have any queries or questions, I am more than happy to answer now or later if you want to contact me via my email. Thank you.
Thank you very much, Prof. Nisreen, for the fruitful presentation and the interesting cases. And the door now is open for discussion. Any question? Any comment?
Should I check the chat box or the questions will be direct?
I can also check the chat box. But I think they're happy. They don't have any confusion.
As far as it's in the boring presentation, I'm
So
happy.
there is a question from Prof. Monty. So please, Prof. Monty.
I think they will be unable to unmute themselves, so they can put things in the chat.
Okay, I'll try to open it. Maybe I should stop sharing the screen. Yeah, to be able to open the chat box. Yes. I can't see messages in the chat box actually.
But we can.
Okay, sorry, I have just uploaded a link. This is the evaluation. So for anyone wishing to have a CPD certificate, please make sure that you spend 2 minutes placing your evaluation, because your feedback is very important to us. So please, for any CPD certificates, kindly access the link, 2 minutes feedback. That would be great. Thank you.
We have here a question from Philip. Would you advise full crown restoration for all teeth treated with palpatomy to ensure good coronal seal?
Thank you for the question. It's an excellent question, actually. It's important at time after you do excavation and do your palpatomy procedure, it's important to evaluate the remaining tooth structure. If you think that there is enough bulk in the buccal and lingual walls of the tooth that it will survive a direct resin composite restoration, for example, like in partial palpatomy, I would just recommend the composite restoration. But in most teeth with full palpatomy, once you de-roof the pulp chamber and you have proximal loss of one of the marginal ridge, I think a crown is indicated for long-term survival. And I would advise placement within the first 6 months after palpatomy, because as I've said that any failure of palpatomy will appear during the first 6 months after treatment. So it's completely safe to place your crown at 6 months. So yes, I encourage placement of a crown for every tooth with moderate to severe loss of tooth structure.
Thank you, Prof. Prof. Monty, would you please write the question on the chat? There is another question from Hamza. What do you think about using vital pulp therapy in third molars and in teeth with complex anatomy?
Of course, I've shown you actually more than third molar. It's many patients, they are actually very keen to keep their wisdom teeth. If the tooth is functional and in occlusion, why not? Even if the symptoms reversible or irreversible pulpitis, once you access and you can achieve hemostasis, you can definitely do vital pulp therapy. With complex anatomy, with straightforward anatomy, I'm not sure if maybe I've deleted a slide. I had a few introductory slides, which I've removed because of the time, where I was showing very complex anatomy of an upper six that you would love to avoid in your root canal therapy. So vital pulp therapy is the solution, but we totally make it because of the main biological and histopathological evidence that we can save the pulp for benefits of the vitality and the proprioception and the survival more actually than the complex anatomy, because as endodontists, we have several means of managing difficult anatomies. Our concern is preserving the pulp at the first point, and second point, you can avoid difficult anatomy.
Any question? One question from Dr. Salim. Do you know how many percentage of vital inflamed pulp with apical radiolucency? Is it very rare?
No, it's very common actually. In one of the screen, I have shown you some studies that have included, but there is no one particular study that looked at prevalence of apical lesion in vital teeth, but you can see it very commonly. The good thing now, vital pulp therapy is gaining popularity, and I'm getting several general dentists who can see now they diagnose vital pulps when they have periapical lesions and they refer it. Most important issue that you have to do vitality tests, cold tests, sensibility tests to be more accurate. Because if you see a periapical lesion, you can't say that this tooth is necrotic, like what I was taught when I was third-year student. It's not valid anymore. You have to do your cold test. If you get a response, then this is a vital inflamed pulp. That's why we have a periapical lesion, and it happens in advance of total pulp necrosis. And you can read about it in Pulp Biology for Seltzer and Bender, and you can see publication by Stashenko, the Japanese group, who first looked at this issue.
More questions or comment? So, any comment? So thank you very much all. And I would like just to say that Dr. Nesrin already confirmed that there is no conflict of interest with the company or any of the products. So I would like to thank you all and see you again in another. There is another question.
Looking at the chat box at the same time, apologies.
Yeah. Can we use endocrine after vital pulp therapy?
I want the person who asked me to first explain me what's an endocrown. Endocrown, yes, it's a crown that you will use the pulp chamber to for retention. Of course you can. Actually, I was present in the European Society ESE meeting in Vienna in 2019, and there was one presentation by a researcher who placed endocrowns even immediately because he is so sure of the success of vital pulp therapy. Yes, of course, you can use it. You have to ensure that you place 3 millimeters of your calcium silicate material in the pulp chamber, and after that, you restore it with whatever you want, conventional core and crown or an endocrown. But you have to pay attention that if, for whatever reason, if you want to place an endocrown, I will advise after 6 months to make sure that you won't get failure. Because if you place it immediately and you get a failure, it will be challenging to retreat, similar like to a post-crown. But it's not a contraindication.
Yeah, another more question. If assessed before as outcome parameter, I don't know.
Is what? Excuse me?
Yeah, if assessed before as outcome parameter, I don't know what you mean.
Symptoms, the preoperative symptoms, you mean?
I don't know.
I could see one question. I would like to ask you, is the change in canal system geometry narrowing and dystrophic calcification? I want to point here that most vital pulp therapy studies are now using the conventional two-dimensional digital radiographs, which actually you cannot make any conclusions regarding the pulp space volume. If we want to assess changes in the pulp space volume after palpatomy, we have to use cone beam CTs for follow-up, and we have to use a special software, as you know, Dr. Raida, on evaluation of changes in the volume. But I've mentioned in the presentation that there is no single study that reports a percentage of calcification after vital pulp therapy procedure, and I assure you that I never had any case of obliteration in our 5 to 6 publications so far, except the one premolar that I have shown you in the presentation for the young child, which was like a calcific material similar to regenerative revascularization procedure. So I wouldn't worry about calcification.
Thank you. Yes, please. So, yes, please, Doctor.
The question that says if assessed before as an outcome parameter, he's the same person. I think he means is calcification as an outcome parameter. Calcification is not an outcome parameter. If you want to look at dentine bridge formation, it's not considered in the outcome assessment criteria as success or failure, because you cannot detect dentine bridge formation on radiographs. It's a histological entity. And all the studies have removed the entire restoration to check if a calcific formation has occurred, but this is not justifiable because you will expose the tooth for contamination and probability of failure. So most dentine bridge barrier occur histologically, and we don't need to see them on the radiograph to assess success. Success is judged by absence of symptoms, functionality, and absence of pathology on the radiographs. This is according to ESE evaluation criteria, according to Zanini et al. 2016, and according to AAE position statement in 2022.
So thank you very much, Prof. Nisreen. And I would like to thank you all and see you in another seminar series event. Thank you so much. Have a nice weekend. Really interesting cases, Prof. Nisreen.
Thank you so much, and apologies for the inconvenience at the start. It was really upsetting, but I think we did well afterwards by catching
it's worthy. Yeah, it's worthy waiting for it. Yeah, thank you so much.
Thank you. Have a good day, all.
Bye bye. Have a nice weekend.
Thanks. Same to you. Bye.
Bye.